In this lecture, we'll examine the perpendicular R mode, specifically where the suction is hooked onto the buccal aspect. When performing an occlusal prep on the palatal aspect of the 20s, we approach the area by applying suction to the right buccal aspect. Since I'm not holding the suction, my left hand is freed up and it assists with mirror retraction to ensure there's absolutely nothing obstructing my visibility. When working on anterior teeth, if the left hand is free, the octragate's wings are raised to prevent splatter, rather than relying on mirror retraction. However, as we proceed to the premolar and molar regions, the likelihood of splatter diminishes. Securing adequate visibility also becomes more difficult due to the patient's oral commissure. Thus, more emphasis is placed on mirror retraction. My right hand finds a rest on the patient's mentum, allowing the handpiece to approach the oral orifice more vertically. In this specific situation, the entire volume of the handpiece head itself takes on the function of the retraction mirror. In this specific scenario, given that the right hand's stability is compromised due to resting on soft tissue, the left hand, having been freed by hooking the suction, firmly grasps the mirror deep within the palm. It subsequently utilizes the index and middle fingers to provide additional support for the handpiece head. When providing this auxiliary support, the fourth and fifth fingers of the left hand get a rest on the left zygoma. Normally, the left hand doesn't have a stable rest, so it's crucial to be cautious not to apply pressure to the patient's nose or eyes with that hand. Now we'll prep the palatal, mesial, and distal interproximal surfaces. For interproximal visibility, the patient's head is rotated right. Suction is placed on the right buccal aspect. The right hand obtains a rest on the premolar area, specifically in the tens region. The free left hand achieves a primary rest with its fourth and fifth fingers on the zygoma, then secures a secondary rest with the first finger on the octrogate wing, and lastly offers auxiliary support to the handpiece head with its second finger. Let's watch the video, like this. After reinforcing stability using the auxiliary support on the handpiece head, proceed with the preparation. This photo shows the moment of secondary support for the handpiece with the left hand, as explained earlier. Typically, when the handpiece feels unstable using only the right hand, especially with a long burr, or when performing a soft tissue rest, it's advantageous to provide secondary support with the left hand in that position. If we analyze the fundamental root factors ensuring the stable movement of the handpiece at this moment, the first factor is the rest that the fourth finger of the right hand secures from the hard tissue in the 20s premolar area. Second is the soft tissue rest for the left hand's fourth and fifth fingers from the left zygoma. The third is the auxiliary rest that the first finger of the left hand gets from the octrogate wing. The stability of this handpiece head movement is fundamentally based on a stable rest. Therefore, if a singular rest feels insecure, particularly one relying on soft tissue, it is beneficial to employ creativity to achieve additional handpiece stability through secondary or even tertiary rests. Next, let's assume a situation in perpendicular R alignment, with the suction already hooked, and we'll consider the preparation of the buccal and its adjacent surfaces. However, if you visualize this situation, you can intuitively grasp that the perpendicular R alignment mode itself is neither appropriate nor convenient for ensuring adequate visibility and access to the buccal aspect. When targeting the buccal and its interproximal surface, the perpendicular L alignment, specifically approached from the left side, is more appropriate than either a parallel alignment or other perpendicular alignments. Therefore, I will be skipping this slide and will not be covering it. Next, let's consider the perpendicular L alignment, specifically when the suction is grasped. Let's start with the occlusal prep. The patient's head turns slightly right and the operator is at 3 o'clock. In perpendicular L alignment, keeping legs together is more comfortable for space utilization. To reiterate, a significant advantage of assist-free dentistry is the opportunity to more creatively utilize the empty, unoccupied space on the left side, where an assistant is typically located. Specifically, its advantages really shine through with this perpendicular L alignment, particularly when preparing the buccal and interproximal surfaces of teeth in the 20s and 40s. Left hand's fourth and fifth fingers rest on the masseter, right hand's fourth finger rests on upper anterior teeth for buccal occlusal reduction. For occlusal reduction on the palatal aspect, move slightly right and rest on the tense premolar area. When employing this perpendicular L alignment, it's essential to first pull the handpiece line, which is connected from the doctor's table on the right to sufficient length, and let it hang freely, so that there is no discomfort during the procedure. On the left, we see the buccal aspect occlusal reduction posture, and on the right, the palatal aspect occlusal reduction posture. The left image shows the rest on the maxillary anterior teeth. However, if the same rest point is used during occlusal reduction on the palatal aspect, it can strain your arm, wrist, or fingers. One general principle of posture states that if a branch like your fingers or wrist is strained, you should try to adjust more fundamental elements like your wrist, arm, or shoulder to resolve it. A general principle of posture is that if you feel strain in a branch, like your fingers or wrist, it's better to resolve it by changing a more fundamental root element, like your wrist, arm, or shoulder. If you feel strain in your neck or back, you should adjust an even more fundamental element, like the patient's head or the operator's body position. If there's a problem with a more fundamental root posture, trying to fix it solely with a less significant branch posture usually leads to considerable strain on the body. Additionally, in both instances, the handpiece's axis is observed to consistently enter perpendicular to the surface of the oral cavity. Now let's look at the prep of the buccal, mesial, and distal interproximal surfaces. This particular case is almost identical to an occlusal prep, but when you're preparing the buccodistal area, you'll need to rotate the patient's head slightly more to the right to help ensure clear visibility of the distal interproximal surface. In the same vein, take care to ensure that your right hand, which is holding the handpiece, does not press upon the patient's nose or face. Let's briefly take a look at the overall preparation process before moving on to the next section. The strokes are performed like this. Next, we'll look at the prep for the palatal and its interproximal surfaces. In this specific case, the perpendicular L alignment mode is rather inconvenient and unsuitable for preparing the target area on the palatal aspect, so we'll omit that method. For this, applying the parallel or perpendicular R mode is much more appropriate. Next, let's look at the posture for the perpendicular L alignment mode while hooking the suction. First, looking at the occlusal target area, the patient's head is turned to the right. The operator is positioned at approximately the 3 o'clock position. The suction is placed at the right corner of the mouth. The free left hand assists with mirror retraction. The suction tip, which is hooked at the right buccal aspect, undergoes 2 bends to form an S shape. It is most appropriate for the initial bend on the main body to be directed outward, while the second bend at the distal tip should be oriented inward. Let's examine buccal, mesial, and distal prep. It's almost identical to occlusal prep. When prepping the distal area, turn the patient's head a bit more to the right and use your free left hand for more mirror retraction to improve visibility. Let's watch this video. Thus, when prepping the distal area, it is beneficial to perform a bit more mirror retraction compared to prepping the mesial section. Because the patient's head is rotated to the right, the suction automatically takes care of absorbing any water that has collected on that side. As I always emphasize, in this perpendicular L alignment, it's crucial to pull the handpiece line far enough, just like in this video, to prevent the cord's tension from getting in the way when you eventually access the target site. Now, this video illustrates the preparation of the bucco-mesial interproximal surface, the target area of a premolar. In this setup, surgical principles such as ensuring clear visibility, protecting adjacent tissues, and securing access are quite well established. However, a slight downside here is that the wrist of the left hand, which is performing the mirror retraction, is notably bent outwards, as shown by the red line mark. Holding this kind of static posture for a long time isn't good for your wrist's health. Among the surgical principles, the element of pain-free posturology is incomplete. So, how can we fix this postural issue? If you've been following the lecture closely, you can figure out the solution yourself. That's right. I have repeatedly explained that by simply correcting a more fundamental, higher-level posture element, you can resolve flaws in the lower-level posture elements. In this specific situation, it appears that by gently turning the operator's body slightly counterclockwise, we can effectively lessen the degree of flexion in the left wrist without compromising or sacrificing the crucial aspect of maintaining clear visibility. Next, let's look at the prep of the interproximal surface on the palatal aspect of the premolar in the 20s. If you take a moment to imagine it, you can picture it, but prepping the palatal and interproximal surfaces in perpendicular L alignment isn't ideal for several reasons, so I'll skip this slide. It is more appropriate to prep this in parallel and perpendicular R mode. Alright, that successfully concludes our lecture on the prep work for the premolar area, specifically in the 20s region. We've covered about 1/6, and I believe this initial part is the most unfamiliar and challenging. Once we fully cover the molar area of the 20s, the same fundamental principles will be applicable to the anterior, premolar, and molar regions of the 40s, 10s, and 30s. Therefore, I implore you to remain patient and persistent. Thank you for listening. This is Teflon tape under $1 per roll. Just pull out a sufficient amount, approximately 8 inches. Fold it over twice, that should make it about 2 inches. Now twist it tight. Keep pulling from both sides and twisting until it can't be twisted any further. We're almost there. Time for cutting. With sterilized scissors, carefully snip 0.15 to 0.23 inch lengths, ensuring they don't fly off. You can make approximately 3 or 4 pieces. The cut ends will be pointed, so carefully knead them to finish. Ta-da! Let's test it. It fits the hole easily. So simple, right?